All right, so it's my pleasure to introduce the next speaker, is Dr. Annette von Drygalski. She is a professor of medicine at the University of California in San Diego in the Division of Hematology Oncology, where she is the director of the Hemophilia and Thrombosis Treatment Center. She also holds an adjunct associate professor position at the Scripps Research Institute in La Jolla. Annette earned her pharmaceutical and medical degrees from the Ludwig Maximilians University in Munich. She then went on to complete her internal medicine training in Milwaukee and hematology oncology training at UC San Diego and the Scripps Research Institute. Annette's focus is on the care of patients with hemophilia and other bleeding disorders, addressing their evolving needs during aging, and evaluating novel therapeutic modalities from the bench to the bedside. She has pioneered musculoskeletal ultrasound for rapid joint bleed detection and has developed approaches to quantify joint inflammation. More recently, Annette has developed a focus on international outreach to establish care for patients with hemophilia and bleeding disorders in Mozambique, and to address risk factors and mortality from postpartum bleeding. This is a healthcare gap that is in urgent need of filling, and I'm thrilled that Annette has agreed to speak on this particular topic. Annette, you're on.
Well, thank you very much for the invitation. It's my honor and pleasure today to talk to you all about postpartum hemorrhage in developing countries. This will be our agenda. We will address the epidemiology and etiology, pathophysiology, coagulopathy, and treatment. We will discuss the anemia and its role in coagulation. We will discuss a case, and lastly, our work in Mozambique. Let's start with epidemiology and etiology. Maternal mortality is very high in the developing world, and especially here in sub-Saharan Africa, as you can see in dark blue. Whereas in the developing world, there might be as many as 300 to 1,000 maternal deaths per 100,000 live births. This is only on the order of 5 to 20 in the developed world. Turns out that PPH, postpartum hemorrhage, is a major contributor to maternal mortality. And that is best shown in this graphic here below. And that graphic charts mortality ratios by cause and region. So as you can see here in red, this is what denotes PPH. PPH is the cause of death in approximately 1/3 of cases, especially high again in sub-Saharan Africa, but with approximately equal proportions worldwide. And so other contributors to death, for instance, are hypertensive diseases, eclampsia, here in orange, or infection, sepsis, or here less delineated in light and dark green, other direct and indirect causes. Now, while overall mortality is low in the developed world here, so this is why at least on this graph, it cannot be scaled, PPH is on the rise. The loss of a mother in sub-Saharan Africa is catastrophic because she often leaves an unprotected family behind. And that is especially sad since PPH is preventable and treatable. It's under-recognized regarding effects of public health, and ironically, with a particularly poor awareness in the locations that are most severely affected. And these locations also pose a difficult environment for reliable data collection. What's the definition of PPH? It's blood loss more than 500 milliliters with vaginal delivery, and that amounts to approximately a volume of 1 to 2 blood transfusions, and more than 1,000 milliliters with C-section. The causes of PPH can be summarized easily by the 4 T's, which is tone for uterine atony, tissue, for instance, retained placenta, trauma, such as lacerations and uterine rupture, and then finally clotting for the coagulopathy. Let's transition to the pathophysiology, coagulopathy, and treatment. And now let's go to the 4 T's. The first T here, tone, is the most important T. It reflects uterine atony, visualized here in this flaccid, uncontracted uterus that is filled with blood. Contributing factors can be prolonged labor, such as muscle fatigue, multiparity, inflammation, infections, and a number of others. The first 3 T's are mostly addressed by obstetric interventions, be it with medications like oxytocin to promote uterine contractions, or local by various means of uterine compression, and then finally last resort surgically by hysterectomy or uterine artery embolizations, whereby embolizations are not easily available in the developing world. And then we come to the fourth T, and that's clotting. Obviously, postpartum hemorrhage can be aggravated by underlying bleeding disorders or by anticoagulation, but these are usually conditions that are known in advance and can be addressed appropriately prior to delivery. The detriment comes in with unstoppable PPH, complicated by conditions such as acute traumatic coagulopathy, disseminated intravascular coagulation, or hyperfibrinolysis, all of which result in a quasi so-called low fibrinogen state. And our hematology interventions, unfortunately, are really restricted or limited by just blood component resuscitation and tranexamic acid. Now, you can easily imagine that these coagulation abnormalities listed here can lead to a rapid hemostasis nightmare, I would call it, aggravated by these three obstetrics T's, and then with amplification lead to catastrophic bleed perpetuation. Now let's talk about low fibrinogen. The importance of adequate fibrinogen levels, i.e. fibrin formation and stabilization, has long been recognized. And just to remind everyone, fibrinogen is an acute phase reactant that's elevated in pregnancy, maybe for a reason. And it's been elucidated in Peter Collins' lab and group in England that it is a strong predictor of PPH. Once levels drop below 200, it has a positive predictive value of 100% for PPH to occur. And conversely, if it rises above 400, it's a high negative predictive value. Fibrinogen is an abundant plasma protein, and its cleavage with fibrin formation are here here within the common pathway. And needless to say, this is why we are here, going back full circle to Earl W, who elucidated all of these pathways. What are the mechanisms of depletion? Mostly consumption. Fibrinogen gets consumed during disseminated intravascular coagulation, for instance, and then early or also hyperfibrinolysis. And interestingly, this process seems to be more pronounced in developing countries. Rapid point of care tests to infer a lowering or dropping fibrinogen are simple clotting assays such as the APTT or PT, but also thromboelastography, which of course is also not easily available in the developing world. In that sense, fibrinogen-directed treatment to elevate levels over 200 have become critical. How can that be accomplished? The first pillar here is fibrinogen supplementation, which can be done but with pure fibrinogen concentrates, which are not available in the developing world. Actually, they're only available in Europe and Canada. They're not even available in the United States. The second pillar here in terms of fibrinogen substitution is cryoprecipitate. It's a plasma product that's enriched in fibrinogen, and you may be surprised to hear that this is also rarely available in the developing world. The second big pillar is the administration of tranexamic acid to stabilize fibrin. The importance of tranexamic acid has been demonstrated in the woman trial, which was published in The Lancet in 2017. The trial was conducted in 21 countries, encompassing 193 hospitals and including over 20,000 women with PPH in double-blind, placebo-controlled fashion, administering 1 gram of tranexamic acid or placebo with repetition possible. And this here are the key results. You can see that tranexamic acid reduced mortality by approximately 1/3, irrespective of the primary cause of hemorrhage, be it uterine atony or something else. Uterine atony was by far the most cause associated with PPH, despite the fact that almost all women had received uterotonics. This is also irrespective of the type of delivery, vaginal or C-section, but it appeared that early administration within 3 hours of onset of PPH was better than late administration. I want to pause here. 1 dose of tranexamic acid costs $3. Let's switch gear now and go to prenatal anemia and its contribution to PPH. How does anemia affect coagulation? PPH is complicated by prenatal anemia, And most PPH occurs in areas where anemia is highly prevalent, for instance, sub-Saharan Africa. The etiology of the anemia is mostly iron and nutritional deficiencies. And that's really nicely exemplified here in this study conducted in a suburb of Maputo, Mozambique, where you can see that 80% of pregnant women have been anemic compared to maybe only less than 5% in the USA. And it's not just mildly anemic, it's moderate or severely anemic. So in that sense, the loss of relatively small blood volumes can be detrimental and result in hemodynamic instability. And also in that sense, Western definitions of PPH may not apply. A woman with a hemoglobin here less than 7 cannot afford to use 500 milliliters of blood. There is increasing evidence that prenatal anemia is associated with PPH, and that was just published here in this meta-analysis, including 550,000 deliveries and studying the association of PPH with anemia. As you can see, these key studies demonstrated that prenatal anemia increases the odds of PPH by approximately 2-fold. And then when these odds ratios were segregated by hemoglobin levels, turns out that a hemoglobin level less than 8 portends a 6-fold higher risk to suffer from PPH compared to a non-anemic woman. But even with mild anemia, here just hemoglobin levels between 10 and 11, there is an approximately 2-fold increased risk. So clearly the risk to suffer from PPH increases with the degree of anemia. That said, the effects of anemia on the rate of bleeding and the physiological response to PPH in the setting of anemia are poorly understood. So what is the role of red cells in coagulation? There is increasing evidence for various roles encompassing the following mechanisms, such as rheology, viscosity, shearing, thrombus composition and stability, and cell surfaces and coagulation. And I will speak to all 3 of those in a moment. But of note, the experimental evidence is mostly in the context of thrombus formation and hypercoagulability, much less in the context of bleed control. So let's start with rheology, viscosity, and shearing. It's known now for several decades that red cells in the bloodstream facilitate platelet diffusion towards the vessel wall, or for that matter, towards a thrombus. And that mechanism is compromised with anemia, where platelets start to trail behind the depleted red cells by convection. This principle was most recently elucidated in Alisa Wahlberg's lab using the converse, namely a higher hematocrit, showing here data with normal hematocrit, and here if the hematocrit is elevated to 60%. And it shows that the abundance of red cells here narrows the near wall depleted cell zone. These little black dots are a thrombus, and thereby intensifying the near thrombus travel time of platelets. That brings us to thrombus composition and stability. This intriguing study, published in Blood in 2014, shows that red cells, here by electron microscopy pictures, shows that red cells make up the core of the thrombus. And when traveling from the outside to the inside of that core, change their shape from biconcave discs to polyhedras. And these polyhedras afford a very tight packing, like a seal. And when then compressed here to the right by a mesh of fibrin and platelets that's mostly forming on the outside of the thrombus, it extrudes all fluid. It's called clot contraction, and that was shown by special MRI. Interestingly, this process is dependent on fibrin and platelet concentration. And so it's conceivable that low fibrinogen states, such as in PPH, coupled with anemia, equal poor clot stability with bleeding. Moreover, red cells and red cell surfaces appear to partake in coagulation by providing intercellular adhesion molecules to mediate red cell platelet interactions, but also by supplying phosphatidylserine for thrombin generation and for prothrombinase assembly, processes that we usually only think of happening on platelet surfaces. And this was shown very elegantly several years ago by Ken Mann's lab. So you can see here in terms of thrombin generation that in various plasma platelet preparations, if red cells are added, thrombin generation increases to what's observed in whole blood. And in this graph to the right here, showing you thrombin generation in a purified system that's supplemented with the clotting factors that can assemble into prothrombinase, namely factor 5A, 10A, and 2. In the graph on top here, in the presence of phospholipids, and on the bottom here, without phospholipids, that's the negative control. Now, if red cells are added to that negative control without phospholipids, you can see substantial amount of thrombin formation, supporting the notion that prothrombinase can assemble on red cell membranes. Additional detrimental effects of anemia have been reported in obstetrics in terms of hypoxia, up or dysregulation of placental vascularity, which may lead to increased peripartum risk. Iron deficiency associated with increased susceptibility to uterine atony, maybe because of tissue iron deficiency, maybe because of impaired oxygen transport with long-lasting anemia, is not quite clear. And of note, those data are scarce, and the literature is more conceptual than evidence-based. With that in mind, I'm truly excited to introduce you to the Woman 2 trial. This is a PPH prevention study in anemic mothers, administering prophylactic tranexamic acid within 15 minutes after umbilical cord clamping. The trial started in 2018 and has randomized approximately 1/3 of the targeted woman number. The trial will be of equal magnitude than the original woman trial. By now, you might ask yourself, why am I the one presenting to you today about PPH? And this is because a collaboration that began in 2017 with Dr. Patricia Silva. She's the chief hematologist at Maputo Central Hospital. And this is embedded into our UCSD Global Health Initiative. And while we initially were bound to improve and establish care for patients with hemophilia, it quickly became clear that PPH is a problem of much higher magnitude and needed attention. So let's start with a case. This is a 33-year-old female. She's 34 weeks pregnant. She is febrile and not feeling well for the last several days. She arrived with her husband after a journey of many hours by chopper, this is what these buses are called, from a rural province. You can see her here in the maternal admission area. She's mildly febrile, but her vitals are otherwise unremarkable. You can see that she is quite anemic with a hemoglobin of 7.5, microcytic hypochromic, suggesting iron deficiency anemia. Her white cells are mildly high with neutrophil predominance, and her platelets are mildly low. She is HIV positive and receives care in a rural healthcare hub, and she has had a history of several episodes of malaria. After admission to the maternal wards, labor begins soon, and the patient oozes at first, followed by overt bleeding peripartum, despite oxytocin for uterine contractions and also despite manual compression. A medical student is sent to the blood bank to receive 2 units of red cells and fresh frozen plasma. Transfusion begins shortly thereafter, but she would need more, and additional red cells are unavailable, we were told by the blood bank. So there is also no availability of cryoprecipitate. The blood bank only provides red cells and fresh frozen plasma. And while tranexamic acid is on the hospital formulary, it's currently not in stock. So our mother here becomes hemodynamically unstable, and she expires 3 hours post-delivery. Her chart documentation is as follows: abnormal bleeding, there is no estimated blood loss, and she also had uterine atony, and as you can see, she had multiple risk factors for that. So cases like this inspired our work in terms of PPH in Mozambique. And towards that end, we just completed and published a study addressing maternal death and PPH in Maputo Central Hospital, with the objective to study PPH, of course, risk factors and mortality to inform future studies and intervention strategies. This was a retrospective analysis of about 500 deliveries within a 6-month time frame, whereby we were only able to estimate to collect 25% of the deliveries. We called it a convenience sample, and this was because it was really difficult to locate all the charts. But we had the autopsy reports from all 35 deceased mothers. And let me introduce you to the team. This is Dr. Momade. He is the obstetric resident. Doctors Luis and Boaventura are senior obstetricians. And this is Lian, the medical student from the UCSD Global Health Program, who actually moved several months to Maputo to collect this data with Dr. Momade. And Dr. Sylvia at her favorite place, the microscope. So here are the key results. Median age was 29 years, 17% were HIV positive with a really high obstetric complication and C-section rate. 54% of the mothers were anemic and PPH rate was 12%, which was probably an underestimate due to incomplete charting. You can see here, relatively most affected were younger women, and then PPH risk rose with age. It rose with the number of pregnancies, and it was higher with a shorter length of gestation. When looking at the labs on admission, which were only available for mothers in distress, which was about half of them, and looking here at hemoglobin, platelets, and albumin as a measure of well-being, malnutrition, etc., you can see that off the bat that many mothers in distress had abnormal lab results. Everything under the blue line is abnormal. But you can also see that these labs on admission were significantly lower in women experiencing PPH later. And that was particularly true for hemoglobin. So diving into this issue a little more intensely, you can see that there was an inverse relationship between the probability of suffering from PPH and hemoglobin levels on admission. In other words, if a woman had a low hemoglobin of 6 or 7, let's say, she was at much higher risk to suffer from PPH than someone with a higher hemoglobin or normal hemoglobin. Now, why is that important? Because there is an association of PPH with mortality. In fact, PPH and HIV positivity were the strongest independent risk factors of mortality, as you can see here in this chart. And when that was graphed in age-dependent fashion, you can see that there is relatively high mortality risk for younger mothers and for older mothers. And there's an increment here in blue if mothers experience PPH, in black if mothers are HIV positive. And if both coexist, PPH and HIV positivity, the mortality risk augments dramatically. In fact, it almost looks like a death sentence. So this work inspired new work in progress, and it's well underway. It's a prospective study that will last about 2 years and encompasses the data collection of every delivery before and after the ability to produce cryoprecipitate. Tranexamic acid is not in the mix here because we don't have control over pharmacy purchasing, etc. So this work is supported by the Stadima Foundation in Munich, Germany. The study start was in January 2020 so far. We have collected approximately 6,500 deliveries. The training to produce cryoprecipitate, as well as equipment procurement, freezer, blood sealer machine, etc., has been completed, and we hope to start with cryoproduction actually this month or next month. And then we will continue data collection and analysis through 2022. We hope that this will establish that the availability of cryoprecipitate as a fibrinogen-rich source will reduce PPH and mortality, and will enable us to work with the Mozambican Ministry of Health to raise awareness and develop guidelines, which may also benefit other sub-Saharan regions. In conclusion, PPH contributes substantially to peripartum morbidity and mortality in the developing world. Anemia is a major risk factor for PPH, whereby the effects of anemia on bleeding and coagulation are not really well understood. And so knowledge of the role of anemia in hemostasis is needed to inform new intervention strategies. And with that, I end. I have many acknowledgements to make, first and foremost to the whole team in Maputo, which you have already met in the previous slides, led by Patricia Silva. at UCSD, Leon Lancaster, Richard Barnes, who is our statistician, and Chip Schooley, who heads our global health program. And then very new to the team from the University Hospital of Freiburg, Charlotte Niemeyer and Hannah Glonecker. Thank you. I'll take questions.
Thanks, Annette. That was fabulous. Can you just unshare so we can all see? That's great.
Let me see how I can do. Yes, just a second.
No problem. And while that's happening, do we have, we're open for questions. You can unmute or you can send in chat questions while people are gathering their thoughts. So I do have a question though about the impact of COVID and the pandemic on you know, the outcomes and the situation there, because I do work in Uganda and I know it's traumatic. Yeah,
Dr. Silva and I had a very intense exchange flying back and forth over the past 3 years, maybe even as much as 5 or 6 times a year to facilitate this study. And obviously with COVID in March, this all came to a halt, but the spirit of the Mozambican team is undeterred and it all continues as it should. And so we do a lot via Zoom now, via telephone. We have combined calls, not always easy because of internet and other things that we take so much for granted, but we will get through it. And as soon as there's a vaccine, we hope we can travel again.
Good.
Hi, I have a question.
Go ahead.
Hello, it's I'm so sorry. It's Ann Shapiro from UCSD. Annette, it's nice to talk to you. I really enjoyed your talk. My question is, in the new women's study, in the new women's trial, are there patient populations that are not being included secondary to having a history of thrombosis, or do we forget about histories of thrombosis and the procoagulable state of pregnancy and go ahead and give the TXA anyway in patients who are at risk of dying from hemorrhage?
I see your concern. I actually don't know that, what the exact inclusion criteria are, but to tell you the truth, I doubt that this would be known coming into the delivery section or area or maternity wards. It's, I think, very difficult to take these women's history. And thrombosis in general, that is my impression, is not a big part of morbidity in sub-Saharan Africa anyways. So I don't think people would even know what that meant to have a thrombosis or a thrombotic history.
There's a couple of questions on chat here. So first, do pregnant women receive iron supplementation there?
Yeah, so we discussed that very frequently with Dr. Silva, who is also on the call and who could probably speak to that perfectly. It's a very different subject, difficult subject there because of malaria and infections. And the moment you start to iron supplement, you also increase the infection rate. And there are a number of studies out, especially in children, etc. If that starts, you set them up. And so there is a fine balance. And what Dr. Silva told me she is doing is if she sees it, she gives it to them. If she is really sure that they have bed nets, that they are not infected right now, that they're afebrile, and that it's sort of stable. And that accounts for oral and for IV. So it's a fine balance.
Okay, a bunch of questions here. Okay, so can you tell us anything about the causes of apparent higher rates of hyperfibrinolysis in developing countries?
Yeah, no, I wished I could not. So this was a publication also from Peter Collins' lab and group, who had done some fibrinogen studies in Nigeria. And turns out that this hyperfibrinolysis, as measured by thromboelastogram, was really an issue and was not observed as much if they did their studies in England. To why that is, I do not know. Maybe more infections, maybe more DIC, maybe just more of these conditions that we don't encounter so often here in the Western world that spur hyperfibrinolysis.
Okay, what is, it sounds like Christian wants to know, what's the ideal next generation antifibrinolytic drug? Is there anything special that you wanted to be able to do?
Of an anti, what do you say?
Antifibrinolytic drug.
Oh, well, as long as it's cheap, it would be great. So if we talk about the developing world, you notice that, for instance, in Mozambique, tranexamic acid was not in stock. This is because it couldn't be afforded, even if the dose per saved life is $3, because there are so many competing requests on a strapped healthcare system that, and as we often said, PPH is not always publicly recognized as being such a big problem, especially in areas that suffer the most from it. So if new drugs come in, that would be great for the Western world, but I don't think that it's applicable for the third world or for the developing world.
Okay, so I'll just give a quick from Maria Patricia Martins da Silva. She just said all the women receive ferrous sulfate and malaria prophylaxis in Mozambique. But I'll jump to a question by Haley Merkley, who's a physician involved in the hemoglobinopathy program here. I'm just wondering about comorbid sickle cell disease in the population in Mozambique. Generally, these women are at higher risk of peripartum thrombosis.
Yeah, you know, again, it comes to the fact that thrombosis is not recognized as a massive healthcare condition in sub-Saharan Africa. In fact, it would be even hard to determine thrombosis. There are no imaging studies, certainly not CT angiogram, and even ultrasound is not always available to look at DVTs, for instance. So I don't think that it's on people's mind that this could be a problem. The problem is really bleeding to death, less the thrombotic risk.
And on that, do they have access to uterine tamponade devices?
Yes, they do have access to uterine balloons, to manual compression. That's the mainstay.
Okay. And is viral hepatitis a risk for postpartum hemorrhage?
Is viral hepatitis like hepatitis C? I don't know that. I don't know. So I know that our study and others show that HIV is, so they are linked. In which matter and intensity is not quite clear, but they are linked, but I do not know about viral hepatitis.
Great. Okay, Annette, I think we'll wrap it up. There's oodles of interest, obviously, on this topic. Thanks for the brilliant presentation on behalf of everybody here. Thank you. I knew it would be great.
Thank you.
Okay, so our next speaker, Shruti, I can see you. So Shruti, while I introduce you, do you want to share your presentation? And you're muted.
That would be great. I'm going to share.
Okay, great. Okay, so while Shruti, she's sharing. All right, Dr. Shruti Chaturvedi is an assistant professor of medicine in the Division of Hematology at Johns Hopkins University School of Medicine. She received her medical degree from the University of Delhi in India and went on to complete a residency in internal medicine from the Cleveland Clinic and a fellowship in hematology oncology from Vanderbilt University. During her fellowship, she also completed a Master of Science in Clinical Investigation with a focus on genetic epidemiology. Shruti has a clinic focused on the care of patients with benign hematologic disorders, particularly thrombotic microangiopathies and the antiphospholipid syndrome. Her research focuses also on thrombotic microangiopathy and the associated long-term vascular complications, as well as the role of complement and other hematologic disorders, including the antiphospholipid syndrome and sickle cell disease. Her work has been supported by grants from ASH, from the Hemostasis and Thrombosis Research Society and the NIH. And I am so pleased to have her here to speak on a topic near and dear to my heart. So Shruti, you're on.
Thank you, Dr. Conway, for that introduction and for inviting me to speak here. It's truly an honor and a privilege. Today, I'll be talking about the role of complement in the antiphospholipid syndrome, as well as catastrophic APS or CAPS. These are my disclosures. I will be discussing the off-label use of eculizumab in the antiphospholipid syndrome, and I'm rather embarrassed coming after the last talk to say that it does not cost $3. This is a brief outline of my talk. After an introduction to APS and CAPS, I'll discuss complement in APS, followed by the role of complement in CAPS, and finally touch on some opportunities and therapeutic implications of these findings. So to start, the antiphospholipid syndrome, we know, is a systemic autoimmune disorder. It's characterized by thrombosis, which can be arterial or venous, and or pregnancy morbidity in the presence of antiphospholipid antibody tests that remain persistently positive. I've particularly like this figure because it highlights to me that APS is different depending on who's looking at it. As hematologists, we worry most about the thrombosis, but the obstetrician may be seeing the preeclampsia or the intrauterine growth retardation of fetal loss, and others may end up seeing findings such as thrombocytopenia, libido, and CAPS. Before I go ahead, I'd like to start with a case. This is a lady that came to my clinic in 2018 when I just started my first faculty position. She was 34 years old with a known diagnosis of triple positive APS. She'd had 5 prior DVTs, including on anticoagulation, which was on warfarin, appropriately dosed, and on Lovenox or low molecular weight heparin. And now she was 15 weeks pregnant at her 4th pregnancy, and she did not have any living children. And this is a pregnancy history. She had a miscarriage at 6 weeks in 2011. 2 years later, she's pregnant again, but is hospitalized at 22 weeks with nausea and vomiting, some shortness of breath and back pain. She's found to have really low platelets. Her LDH is elevated. She has elevated liver enzymes and a new portal vein thrombosis despite being on therapeutically dosed low molecular weight heparin. And she's diagnosed with HELLP syndrome and eventually delivers a stillborn male infant that is affected with intrauterine growth retardation. 3 years later, in 2016, she's pregnant again, and this time she's on aspirin in addition to therapeutically dosed low molecular weight heparin, and is admitted with scapular pain at almost 21 weeks. She's found not to have a pulmonary embolism, but develops thrombocytopenia, elevated LDH and liver enzymes again. Unfortunately, again, delivers a stillborn infant. And 4 days after this delivery, while she was initially recovering, develops worsening thrombocytopenia, renal failure, infarction of her liver, and elevated LFTs, new clots while on anticoagulation. And at this point of time, she's diagnosed with either a postpartum variant of HELLP syndrome or CAPS, treated with steroids, heparin, and plasma exchange, and left the hospital only after 6 weeks in the ICU. And this case highlighted to us many things, but importantly, the fact that APS has pleomorphic manifestations, and the obstetric manifestations in particular can be broad. Also, to me at the time, it was remarkable that it was really difficult for me to tease apart whether we're dealing with HELLP syndrome or catastrophic APS, with the only thing to really tease it apart is that her manifestations often occur after delivery, which suggests perhaps this is CAPS. So when we talk about the antiphospholipid syndrome and its manifestations, we briefly talked about the clinical manifestations. But in terms of the lab tests that are required for diagnosis, there are multiple tests that include the detection of a lupus anticoagulant in vitro, which can be done by a multitude of tests listed here. Antibodies against beta-2 glycoprotein, which could be antibodies against domain 1 or other domains. And there is some recent data suggesting that antibodies directed against domain 1 may be more pathogenic, although this remains an area of investigation. Then we've got anti-cardiolipin antibody tests and also other tests such as anti-phosphatidylserine or anti-prothrombin antibodies and others. And the clinical relevance of these is less certain. Overall, in terms of clinical significance, it really goes from left to right. The lupus anticoagulants seem to be the most clinically meaningful, followed by the beta-2 glycoprotein antibodies and so on. And overall, most people believe that the IgGs are more relevant than the IgMs, and the significance of the IgAs is much less certain, and the IgAs are not included in diagnostic criteria either. Overall, while the lupus anticoagulants may be the most predictive as a single marker of thrombosis, being triple positive, which means having a positive test for the lupus anticoagulant, a positive anti-beta-2 glycoprotein antibody, and an anti-cardiolipin antibody test, gives the highest risk for either a first thrombosis shown here. So over here, we've got events per patient years on the y-axis, and we see the rate in normal individuals, patients with single positive assay, but no prior history of clotting, or triple positive carriers here. And the rate in triple positive carriers is about 5.3% per year, which is quite high. Similarly, triple positivity appears to be one of the best markers to predict recurrent thrombosis. This is a figure that shows the cumulative incidence of recurrent thrombosis in patients with triple positive APS over time. Of these 160 patients, 123 were on long-term anticoagulation. Shown here in the dark blue line is the rate of recurrent thrombosis in patients who were not on anticoagulation. And the gray line here is the patients that were on anticoagulation. And this is the one I'm particularly interested in because, if you look at year 5, 6 onwards, there's a 20% or higher rate of thrombosis, which is much higher than we expect in many other thrombosis populations. However, triple positivity does not always identify patients at risk for CAPS or anticoagulation failure. And this is an area that still needs more work. In terms of recurrent thrombosis, this is what many of us will worry about as treating hematologists. And indefinite anticoagulation with warfarin has been shown to be the standard of care in the antiphospholipid syndrome. Now, two trials have shown that whether it's triple positive APS or APS that is all comers, the direct oral anticoagulants appear to have higher rates of recurrent thrombosis, so they're not preferred in this situation. Many series suggest that there's a high rate of recurrent thrombosis on stopping anticoagulation. There's one systematic review that estimated a rate that was 40% higher than thrombosis populations without antiphospholipid antibodies. And anything between 10 to 60% has been reported in different studies. The challenge here is that most of the reports of recurrent thrombosis on anticoagulation come from retrospective studies from large specialized centers. So there may be a selection bias where just the sicker patients are being referred to these centers. And importantly, in the randomized trials in antiphospholipid syndrome, in particular, the recent ones that evaluated rivaroxaban versus warfarin, the baseline rate of recurrent thrombosis at either 1.5 years or 3 years was approximately 3 to 6%, which is a lot lower than quoted in the retrospective studies. However, it's clear that there is a small group that is clinically challenging and appears to have anticoagulation refractoriness or recurrent thrombosis on anticoagulation. The prevalence of this remains unknown, but I suspect it's quite small, in the range of maybe less than 1 to 2%. And next, we have catastrophic APS, which is fortunately rare, occurring in less than 1% of patients with APS, but is still associated with anything between 30 to 50% mortality despite best available therapy. Clinically, it's characterized by rapidly developing and widespread thrombosis that's often associated with multi-organ failure. And the diagnostic criteria require thrombosis in 3 or more organs or tissues, developing within a week, with positive antiphospholipid antibody tests that are repeated at least 12 weeks, and biopsy showing small vessel thrombosis. If a patient meets all 4 criteria, it's termed definite CAPS, and 3 criteria would make it probable catastrophic APS. As of 2020, the standard of care includes anticoagulation, corticosteroids for immunosuppression, and either plasma exchange or IVIG, with rituximab being used commonly for refractory CAPS. Still, mortality rates are in excess of 30%. So in this landscape, we've got the spectrum of APS severity, so to speak. There are patients that have antiphospholipid antibodies, but are carriers and will never have a thrombosis. There are others that have one thrombotic event, and that's it for them. And then there's a smaller group that has either multiple thrombotic events or thrombosis that's refractory to anticoagulation. And finally, a small number of people with catastrophic APS that carries high mortality and morbidity. So in this setting, there are several key issues. One is that treatment for refractory APS and CAPS remains suboptimal. We have some biomarkers to predict risk, but they are suboptimal, particularly when we're trying to predict anticoagulation failure or catastrophic APS risk. And finally, our understanding of the mechanisms that underlie APS and CAPS is incomplete. And that brings me to complement, which may be the key to some of these questions in APS. Before I dive into complement, I'd like to acknowledge some of the existing information or existing knowledge about mechanisms of the antiphospholipid syndrome. There are B cells that lead to generation of these antiphospholipid antibodies, some of which are pathogenic, particularly ones that are directed against beta-2-glycoprotein 1. And these antibodies appear to have multiple interactions that can lead to thrombosis of obstetric problems. That includes activation of cells, which is the endothelial cells or inflammatory cells, including neutrophils and monocytes. When cells are activated, they become more procoagulant. They express molecules such as E-selectin and tissue factor that increase the procoagulant state and can also be associated with mitosis. There are interactions with the coagulation system. And finally, there is interference with trophoblasts and desicule cells that appears to be inflammation mediated. And there has been recent data that suggests that complement activation may underlie many of these effects. So why are we worried about, or why are we interested in complement in the antiphospholipid syndrome? What we know about complement is that it is a part of the innate immune system. There are more than 50 soluble or membrane-bound proteins that are involved in it. And there are essentially three major pathways of complement activation. The classical pathway that is activated by antigen-antibody interactions, the lectin pathway that is activated by bacterial products, and the alternative pathway that is constitutively active but can also be activated by multiple stimuli. Through a series of enzymatic reactions, these pathways all converge to form the C3 convertase that breaks C3 up into C3A and C3B, not shown here. C3B goes on to form the C5 convertase that breaks C5 up into C5A and then C5B, which further combines with other components to form the membrane attack complex, which is C5B29. And in blue here, C3A, C5A, and C5B29 are the effectors of complement. Amongst many other functions, they also contribute to thrombosis either through direct tissue injury or by interacting through tissue factor. In the antiphospholipid syndrome, we know that complement is critical for antiphospholipid antibody-induced thrombosis and pregnancy loss in animal models, in which antibodies from patients with APS are passively transferred into mice. Amongst patients with the antiphospholipid syndrome, there is serologic evidence of complement activation in the form of increased amounts of complement activation products in their sera. However, the association with clinical events in these studies has been somewhat inconsistent. And finally, there are case reports of eculizumab, a C5 inhibitor, being effective in patients with either catastrophic APS or refractory APS. And here's some of the animal data. It appears that deficiency of complement component C4 or C5 protects against antiphospholipid antibody-induced fetal loss. So in these experiments, antibodies from patients with antiphospholipid syndrome were passively transferred into these mice, these female mice. And in a wild-type mouse, fetal absorption was a lot higher, shown here, compared to either a C4 deficient mouse or a C5 deficient mouse. For the mice that did achieve viability and viable births, the birth weight was also higher in the complement knockout mice, suggesting that these complement components were necessary for the antiphospholipid antibody-mediated effects. Similarly, in a passive transfusion model of antiphospholipid syndrome and thrombosis in mice, when antibodies from a patient with antiphospholipid syndrome were infused into a mouse with lipopolysaccharides as a trigger, it led to thrombosis seen here in white. However, if these antibodies were APL negative antibodies or taken from an individual that does not have antiphospholipid syndrome, it led to less or no thrombosis, with the other variables being the same. Finally, when experiment one, where antiphospholipid antibodies from a patient were passively transferred to a mouse, but this mouse now either is deficient in C6 or has a C5 inhibitor added, led to less or no thrombosis. And further, IgG and C3 appeared to co-localize in the blood vessels, suggesting a role for complement in the antiphospholipid antibody-mediated thrombosis, showing that we do need complement for antiphospholipid antibodies to have their thrombotic effects. Coming to patient data, there are multiple studies that show, for example, that C5b9 is increased in patients with antiphospholipid antibodies in stroke compared with patients without antiphospholipid antibodies in stroke. APS patients appear to have high levels of complement activation products BB and C3A in their sera. And finally, there is hypercomplementemia that has been noted in primary APS sera. However, as I mentioned before, the association between all of these serum markers and antiphospholipid antibody-related clinical events was not certain. So we used the modified HAM assay, which is a functional assay for complement activation that was developed in Rob Brodsky's lab to evaluate complement activation in APS. The principle of this assay is that a PNH cell line that lacks surface CD55 and CD59 is exquisitely sensitive to complement-mediated cell death. So if we take these Piguet null cells and expose them to serum with activated complement from a patient with a complement-mediated disorder, these cells die and become non-viable. However, if there's control serum that does not contain activated complement, these cells should remain alive, and cell viability can be detected in multiple cell viability assays, and we used WST1 here. And this assay has been validated in multiple populations with TMAs. And based on prior experiments, we established a threshold of 20% non-viable cells as a positive assay. And at this threshold, it's got a sensitivity of 100% and a specificity of almost 95% to distinguish a complement-mediated TMA, such as atypical hemolytic uremic syndrome, from a non-complement-mediated disorder, such as TTP or normal patients. So when we use the modified HAM assay on a prospectively and collected set of samples from patients with either lupus, antiphospholipid syndrome, or catastrophic APS, we found that the proportion with a positive modified HAM assay, which is greater than 20% cell death, was much higher in catastrophic APS at nearly 86%, and still high at about 36% in patients with APS, compared with only about 7% in the SLE group. In fact, in the CAPS group, we had 7 patients to study, of which 6 had a positive assay, and the one that did not had the sample corrected 5 or 6 days after recovery from their episode. Next, we wanted to look at whether a persistently positive modified HAM assay predicts recurrent thrombosis. So in this figure here, you see cell killing in the modified HAM assay on the y-axis, with the dotted line at 20% marking the threshold for a positive test. And there is time on the x-axis. We've also divided patients into people with either a single thrombosis in blue or recurrent thrombosis in red. And here is a line at 1 year. You'll notice that the majority of patients that continue to have a positive assay after the 1 year point are these red triangles, which is patients that continue to have recurrent thrombosis despite anticoagulation for the most part. Shown in this figure is the recurrent thrombosis rate in patients that were MHAM negative versus MHAM positive. And if they had a positive modified HAM assay, the rate of recurrent thrombosis was over 66%. And what was particularly concerning is this darker red block here, which is patients that had recurrent thrombosis on anticoagulation. In a complementary assay, no pun intended, we looked at C5b9 deposition induced by APS sera. What's not shown here, but was also done, is we extracted the anti-beta-2-glycoprotein antibodies and added them to normal sera to ensure that it is the antibody and not another serum component causing these effects. And what you see here is C5b9 deposition in the lower right quadrant here with normal human serum, or with sugar toxin, which is one of the positive controls that we use. I apologize, I appear to be having a technical issue. Here we go. When we looked at patient serum, APS1 is just one of our patients, we see that C5b9 deposition was markedly increased. Next, we wanted to try to figure out which pathways are involved. So we used a factor D inhibitor, which is ACH4471 from Achillion, and a C5 inhibitor, which blocks the terminal pathway. The factor D inhibitor here blocks only the alternative pathway. And what we found was that C5b9 deposition was not blocked by the factor D inhibitor, but was almost completely blocked by the terminal complement inhibitor, or the C5 inhibitor, suggesting that complement activation and APS is occurring primarily by the classical or lectin pathways and not by the alternative pathway. This was also borne out in the modified HAM assay, which you see here, where there was a negative assay below 20% with normal human serum, a positive assay with the positive control sugar toxin, again positive with patient serum, not blocked by a factor D inhibitor, but completely blocked by a C5 inhibitor. Multiple mechanisms have been proposed in terms of complement activation caused by antiphospholipid antibodies. Some of these include immune complexes in APS binding to C1q and activating the classical pathway, or the fact that beta-2-glycoprotein 1 itself may inhibit complement activation by enhancing C3 and C3b degradation. So when we have antibodies against beta-2-glycoprotein, this may inhibit this process. And finally, it's been proposed that anti-beta-2-glycoprotein antibodies might inhibit factor H activity. Data supporting this is that some patients with APS appear to have antibodies against CFH. Patients with APS appear to have reduced levels of CFH in their serum. And finally, adding factor H back to the system can reduce antiphospholipid antibody-induced hemolysis and AP50 assays. So the next thing I'd like to tackle is complement activation and complement mutations in CAPS. Similar to the figure I showed you previously, this is C5b9 deposition with serum from patient with CAPS. As before, this is normal serum and EDTA and normal human serum, both negative controls. There is increased activation or increased deposition of C5b9 with chigatoxin, a positive control. Again, this is CAPS serum plus EDTA, which should inactivate complement. So we're not seeing C5b9 deposition, but in CAPS sera, C5b9 deposition is significantly increased compared to the negative control or normal serum here. And it is only partially blocked by a factor D inhibitor and completely blocked by a C5 inhibitor. What was also interesting here is that for this particular patient, we were able to get a sample when they were asymptomatic and also a sample when they became sick with CAPS. And the asymptomatic sample was negative, which was drawn prior to getting sick with CAPS, and the acute phase sample was very positive in the modified HAM assay. Next, we sequenced patients with CAPS as well as multiple control groups to look at the rate of rare germline variants in complement genes. And let's start with our controls here. So our positive control group here was atypical HUS, which had a mutation or variant rate of approximately 51%, which is what we expect based on the literature. Our healthy controls had a variant rate of about 23%. However, the CAPS patients had a much higher variant rate of 60%, which was in the same range as our atypical HUS patients and much higher, which was statistically significant from our normal individuals, but also patients with lupus without thrombosis and antiphospholipid syndrome, but not CAPS. And we looked at which variants were present in these patients. Some of these are the ones that we would expect to see in patients with atypical hemolytic uremic syndrome, such as the homozygous CFHR1, CFHR3 deletions, or thrombomodulin. But we also found that 2 patients had variants in CR1, which has not previously been reported with atypical HUS. Based on our data, we proposed a multi-het model for CAPS, in which we have antiphospholipid antibodies that may activate complement. And in the presence of a trigger, which could be pregnancy, inflammation, or surgery, can lead to clinical events associated with these antibodies, such as thrombosis, miscarriage, or HELP. However, in patients with CAPS, in addition to these complement activating antibodies, patients may have an inherited predisposition towards uncontrolled complement activation, either because of a gain of function mutation in an activating gene or a loss of function mutation in an inactivating protein. And in the presence of a trigger, this might lead to disseminated thrombosis and multi-organ failure because these patients cannot regulate complement. So let's go back to our patient. She's now in pregnancy number 4, and we see her at 15 weeks when she was asymptomatic and her MHAM was negative. We got another sample at about 23 weeks. She was still doing well. However, her modified HAM assay here had turned positive. And then actually 5 days after this happened, when she was nearly at 24 weeks, she developed low platelets, renal failure, and LFT elevation, required an emergent cesarean section, plasmapheresis, and steroids in addition to heparin, and was hospitalized for about 2 months before recovery. Additional assays showed that C5b9 deposition was confirmed by flow cytometry. And when we tried to do blocking experiments, again, this was partially blocked by a factor D inhibitor, which blocks the alternative pathway, and completely by an anti-C5 inhibitor, or sorry, an anti-C5 monoclonal antibody, suggesting that activation is occurring primarily through the classical lectin pathways and perhaps a little bit through the alternative pathway in this patient. And she also had a CR1 variant. Now, one question you might want to ask me, and we certainly asked ourselves, is why are we calling this CAPS and not the HELP syndrome? Because it was so difficult to tease them apart. And in fact, HELLP syndrome may be very similar to catastrophic APS. It's a severe form of a hypertensive disorder of pregnancy or preeclampsia, and occurs in about 0.1% of all pregnancies, but is much more common in women with the antiphospholipid syndrome and can be found in up to 10%. And what's really important here is that in women with the antiphospholipid syndrome, HELLP may occur early, which means earlier than 34 weeks, and sometimes even earlier than 24 or 28 weeks. And this is critical because fetal and neonatal outcomes are abysmal if you develop HELLP earlier than 28 to 34 weeks, with high rates of either neonatal death or morbidity. Here is the Tennessee classification for diagnosis of HELLP, which includes hemolysis, elevated liver enzymes, and low platelets, which overlaps with the clinical manifestations of a lot of thrombotic microangiopathies. And one of my colleagues, Jason Vaught, is a high-risk obstetrician, and he looked at the modified HAM assay as a way to identify complement activation in women with HELLP. And what he found here is that 62% of women with HELLP syndrome had a positive modified HAM assay. As a comparison, it's about 88% in patients with atypical HUS and only 11% of healthy pregnant controls. When he sequenced these patients, he found that 46% of the women with HELLP had a rare variant in the complement gene. And there was almost perfect overlap between the patients that had these rare variants and positive modified HAM assays. So finally, coming to therapeutic opportunities here. Now, complement inhibition has already been used for patients with APS who have refractory thrombosis. This report was published in 2016 by Maroney and colleagues, where a 59-year-old woman with APS had multiple thrombotic events, starting with a DVT and PE, followed by occlusion of her tibial arteries in 2005, skin ulcers in 2007, and started to develop recurrent arterial occlusion and skin ulcers even on warfarin. And eculizumab was used to successfully allow femoral popliteal bypass surgery because she was otherwise continuing to have recurrent thrombosis. Interestingly, in this case, there was, when they got the explant, they stained it for beta-2 glycoprotein, as well as IgGs and complement components, and found that the complement components C1, 3, and 4 co-localized with beta-2 glycoprotein, suggesting that this is the classical pathway being activated, which is in line with some of our results. And beyond refractory thrombosis and APS, there are multiple case reports that eculizumab is successful in salvaging patients that have CAPS that is refractory to things like plasma exchange, anticoagulation, and steroids. The challenge with this kind of data is that there is a large amount of selection bias or publication bias because poor outcomes are less likely to be reported. And there have been 2 small series of 3 patients each showing that eculizumab, or anti-C5 monoclonal, prevents recurrent APS and CAPS and to allow successful kidney transplants in patients who lost their kidneys because of APS, or can salvage post-transplant TMA after renal transplantation for APS nephropathy. There was a recent French series which was very interesting, where they did a retrospective dive into their data and found 11 triple positive patients with APS who developed catastrophic APS and were treated with eculizumab. Of these patients, 9 met criteria for probable APS and 2 for definite CAPS. And all of them had been refractory to anticoagulation, steroids, and plasma exchange. And only 5 of them responded to treatment. Now, this isn't quite what we'd expected based on our preclinical data, but they also highlighted that patients that did not respond were more likely to already be on dialysis before starting treatment. Perhaps their disease was too far progressed. But more interestingly, responders had a lower platelet count and a TMA-like picture. So is it that there is a subset of CAP that behaves more like a thrombotic microangiopathy that is likely to respond to complement-directed therapy? So do we need to revisit our CAPS criteria? The criteria that I outlined earlier include involvement of 3 or more organs or tissues with thrombosis within 1 week with positive antiphospholipid antibody tests and biopsies showing small vessel thrombosis. It can be challenging to get patients to fit into these criteria because, for example, it's hard to get biopsies in someone who has low platelets and is anticoagulated. Some patients may not live long enough for testing 12 weeks later. And what happens when the third thrombotic event occurs not within a week, but maybe 10 or 14 days after the first one while on anticoagulation? You miss one, it becomes probable APS, but if you miss more than one, which is not challenging, the patient doesn't get labeled as a catastrophic APS. So this was a series of 152 ICU admissions in APS patients, and the investigators classified them by the existing criteria as either definite caps, probable caps, or not caps. And what they found was that these definitions didn't really impact mortality because mortality was about as high in patients that did not get a definite or probable caps diagnosis as those that were definite caps. And as I mentioned before, the reasons for not meeting criteria is usually missing data, where biopsy wasn't done or antiphospholipid antibodies couldn't be repeated, less than 3 organs involved, or evolution over a slightly longer period of time. Importantly, thrombocytopenia and thrombotic microangiopathy are not included in these diagnostic criteria. And we've been trying to look at our data set to see whether adding thrombocytopenia to these diagnostic criteria improves prediction for poor outcomes, but that is a work in progress, and I'm very happy to take suggestions there. So in conclusion, thrombotic APS and CAPS appear to be associated with complement activation. Anti-beta-2-glycoprotein antibodies themselves activate complement, and CAPS is associated with rare variants in complement genes. Future research that our group and others are working on are the mechanisms of complement activation by antiphospholipid antibodies, functional evaluation of these variants, and the role of complement activation, or the association of complement activation and long-term outcomes of antiphospholipid syndrome in a prospective study. Importantly, some of this data provides rationale for a clinical trial of complement inhibition to reduce mortality and morbidity in anticoagulant refractory APS and CAPS. And this is something that we hope will happen in the next year or two. Finally, I have to acknowledge our research team. Rob Brodsky is my primary mentor, and his lab has done most of this work. And Shruti and Jia are amazing in his lab. We also have collaborations with Cleveland Clinic with Dr. McRae and Dr. Crowther from McMaster University, who has been an incredible support and helped us so much with patient recruitment. Thank you. Thank you for your attention, and I'd be happy to take any questions.
Shruti, thanks very much. Unfortunately, you're a bit over, so we're going to have to skip the questions, but I encourage people to contact Shruti with any questions. You can reach her through chat or by email, okay? So Shruti, thanks again. Fantastic presentation. Very interesting.
Thank you, and I'm so sorry for going over.
Yeah. Okay, but that's okay. We'll move on. All right. And our next presenter. Okay. Mary, are you there? You're there. Fantastic. Okay. Mary is just rushed, I know, from the American Heart Association across the country to give us a talk. But I'm going to introduce you, Mary. All right. So Dr. Mary Cushman, she's our first Earl W keynote speaker of the day. Mary is a professor of medicine in the Division of Hematology Oncology, a professor of pathology and lab medicine, co-director of the Vermont Center on Cardiovascular and Brain Health, and vice chair for emerging researchers. She is also the medical director of the Hemostasis Thrombosis Program at the University of Vermont Medical Center. And I think I probably left out a few additional responsibilities that she has. Mary completed her training in medicine, internal medicine, hematology, and hemostasis at the University of Vermont, followed by a master's in epidemiology at the School of Public Health at Harvard. There was no question of her being recruited back to Vermont, where she has obviously flourished and has had and continues to have a huge impact as an internationally renowned clinician, scientist, and educator. She's authored more than 600 peer-reviewed original articles, multiple guidelines, society statements, reviews, commentaries, and she's amongst the most cited authors in the world of medical science. Mary's research interests address the causative factors for heart disease, stroke, cognitive impairment, and venous thrombosis. And to that end, she's a principal investigator on the long-standing reasons for geographic and racial differences in stroke study, which is the topic of her presentation today. But she's also an investigator on multiple other studies involving atherosclerosis and naturally COVID. Dr. Cushman gives back to the community in so many ways, and I really don't have time to list all of her contributions. Most notably, she has held multiple leading capacities for the American Heart Association and its various affiliates, as well as the Hemophilia and Thrombosis Research Society. She is the inaugural editor-in-chief of Research and Practice in Thrombosis and Hemostasis, a journal that has truly brought the ISTH into the modern world of online communication. And between breaths, Dr. Cushman is a master on Twitter, recognized by her handle Mary Wear a Mask Cushman. There, she most effectively disseminates relevant breaking news in science and medicine. And if you want to keep up on what's happening, I highly recommend that you follow her. We are thrilled that Dr. Cushman is a keynote speaker for this Earl Davie Symposium. Mary, you're on.
Thank you so much. And thanks for the generous and kind introduction. And I'm so thrilled to be here. I made the trip at light speed from Dallas to Vancouver in a matter of 20 minutes. It was quite exciting trip, but really it's great to be here with all of you today. And I'm just sorry that Earl Davie is passed before this conference and I was unable to meet him. So we're going to talk about racial disparities in stroke. And to do this, it's important for all of us to be on the same page about basic stroke facts. Stroke is the 5th leading cause of death in the United States, and it's the #1 cause of disability. #1 cause of disability. It robs people of their functioning. About 800,000 Americans annually have a stroke. And I'm sorry, this is a US-centric talk because I'm discussing a US-centric problem today. Every 40 seconds, someone has a stroke. Stroke also leads to cognitive problems and dementia, and even silent stroke contributes to that. This slide shows the stroke risk factors that are well recognized, and there is a Framingham stroke risk scale, for example, just like the Framingham heart disease risk score. And these factors originate in childhood. So studying the origins of childhood health are important also to contribute to understanding stroke risk in populations. There is a pervasive racial disparity in stroke in the United States affecting African-American people. Stroke death rates 2 times greater. And this has persisted over 70 years. So even in the last 20 years where stroke death rates have declined pretty dramatically because of risk factor control, stroke death is still disparately affecting African-Americans. And this disparity is not seen in other minority race ethnic groups in the United States. So we designed and were able miraculously to get funded as an R01 application back in 2002, this large observational cohort study, the reasons for geographic and racial differences in stroke or regards cohort. And the funding for this comes from the NINDS and now the NIA as well. The regards team is centered at universities, but our participants, as you will see, are not at our places. And my role in the study is to serve as the central laboratory for the study. We implemented a groundbreaking design because we also were studying geographic differences in stroke, and I'm not going to be talking about that today, but there is this phenomenon known as the stroke belt in the Southeast, and we wanted to also study why that exists and what could be done about it. So we recruited participants by mail and phone and did a baseline interview with a computer-assisted telephone interview system down at UAB, University of Alabama at Birmingham. We then engaged with a company that went into the homes of each participant for physical exam, blood draw, and other testing. And the blood samples were processed in the field and shipped overnight to our lab at the University of Vermont, along with urine samples. The participants are followed every 6 months by telephone to ascertain stroke outcomes and to do cognitive function testing. So this sort of shows what it looks like, the participant being seen in their home, their blood being drawn. DHL was our shipper at the time. EMSI, the company we worked with, was the #1 client of DHL. So we were able to get good discounts on overnight shipping. And up in the right-hand corner, you see the building where I am sitting right now, where I rarely am these days, our laboratory in Colchester, Vermont, in northern Vermont. This is what it looked like during the enrollment phase, up to 100 or more individual participant boxes coming in on a Tuesday through Friday basis. And the samples were reprocessed here, spun at high speed in a refrigerated centrifuge, serum and plasma, urine placed into ultra cold freezers in our biorepository. And ultimately, with 30,000 participants, we accumulated 24 chest freezers full of samples, 500,000 aliquots. This is where the participants are. So you can see first that there's a concentration in the Southeast because we enrolled about half the participants in the Southeast, about half African-American, shown in blue dots, and about half white, shown in the red dots. And the age range was 45 to 100, 30,239 participants. We are so grateful to their contributions. We cover a huge portion of the United States in terms of the counties. There's 3,007 counties in the United States, and we have participants in 1,855 of these counties. So what have we learned to date? So this is a format for several slides I'm going to show. And what I will be describing here is the impact of risk factors on the racial disparity. So the hypothesis initially was that disparate levels of stroke risk factors would explain the racial disparity. And so here you see the shape of the association of race with stroke in the cohort. And what you see is that there's this difference in the association of race with stroke risk by age, so that people in their 40s have about a 3-fold greater risk of stroke if they're Black compared to white. And then as age increases, that racial difference dissipates, so that once you get into the 70s and 80s, there is really no longer a racial disparity in stroke. So this is really bad because stroke is the #1 cause of disability, as I told you. And so we're reducing years of productive life in those who are affected, who are young, African-American and women. So this slide shows what happens when you add risk factor levels to this model and recalculate the hazard ratio for race on stroke. And what you see is a reduction in that hazard, so from about 3-fold to about 2-fold. So the risk factor levels, the prevalence of risk factors at baseline, are explaining that portion of the racial difference in stroke at young ages and even into the 50s. When you add socioeconomic factors to that model, you see very little additional attenuation. So really it's the prevalence of risk factors that is driving this portion of the racial disparity, not so much socioeconomic factors after you adjust for risk factor levels. So in essence, we have about half of the racial excess in stroke risk due to traditional risk factors. And again, I'm listing them here to remind you. So we delve further into blood pressure. So hypertension is the most important stroke risk factor. And in this analysis, we're looking at the hazard ratio of stroke for every 10 millimeter mercury higher level of systolic blood pressure. So you see on the left that in Black and white participants combined, you see about a 15% increase in the stroke risk for every 10 millimeters higher the systolic blood pressure. And that's adjusted for antihypertensive medication use, as well as age, race, and sex. When you stratify on race, what you see is this relationship in white people is about an 8% higher risk, or 1.08 hazard ratio, while in Black people, it's a 24% higher risk. So the relationship of systolic blood pressure to stroke risk in a Black person is 3 times greater than that same relationship in a white person. So the risk factor is more potent of a risk factor in a Black person. And then even when we account for the rest of the stroke risk factors, this race difference in the relationship stays the same. So we are working on blood pressure, and currently we're studying why Black people have a higher risk of developing hypertension in the first place. So we're backing up from not predicting stroke, but to predicting the risk factor. And in these analyses, we were able to get funding for a second in-home visit 10 years after baseline, where we could classify people as to whether they developed hypertension over the course. And we have reported that poor diet and high dietary salt, as well as obesity and lower education and income are part of the explanatory factors for this, but they don't explain it completely. And in data that's hopefully nearly published, Tim Plant here at UVM is reporting on the role of higher inflammation in Black people as a mediator of that racial difference in hypertension risk. So to summarize the traditional risk factors, they explain about half the racial disparity in stroke. And so we think of blood pressure in particular as the triple curse. And I didn't show you this, but high blood pressure is more common in Black people than white people in the United States. It's more difficult to control. It requires more medications. And as I showed you, it's more potent as a risk factor. So the triple curse suggests that treatment goals for blood pressure may need to be different in Black people, and that all efforts to prevent hypertension in the first place, or primordial prevention, should be undertaken. And also I showed you that there's still some unexplained disparities. So the risk factors explain about 50% of the relationship, and then we have this percentage that's unexplained. So we questioned whether genetic or other biological factors that we could measure using the biorepository in regards might help elucidate other causes for this difference. And biomarkers can be considered both as mediators and moderators. And a mediator is a biological process that's in the pathway to disease. And that can be either direct or via the impact of risk factors. A moderator would be like a race-specific risk factor, or a risk factor that is unique to African Americans and not as important in white people. And none of this is to ignore the sociocultural impacts of race. Race is a social construct, not a biological one, but the biomarkers reflect all of what's going into that fact. So we have a variety of investigators over the years that have been working on this, ranging from medical students to graduate students, postdocs, and faculty members here at the University of Vermont. And the study design for this is a case cohort study. So this is embedded within the larger regards cohort. And in a case cohort study, you study only those with outcomes and a subset of the rest of the people. And you have your baseline risk factor assessment, in this case, derived from blood samples that we stored. And we ascertained, in this example, 650 cases of people who developed stroke during the first 5 years of follow-up of the study. And we select a random sample of the entire cohort to serve as a control group. So we'll be discussing genetic-related biomarkers, and the examples here are sickle cell trait, elevated lipoprotein (a), and blood group, and also circulating proteins, including cytokines and coagulation factors. So sickle cell trait, we realized over the course of conduct of the study that this posed an obvious candidate to explain racial disparities in stroke. And in the United States, sickle cell trait is much more common in African Americans than other groups. About 8% of our population are carriers of a sickle cell trait, or hemoglobin S. And we know that both sickle cell disease and sickle cell trait pose prothrombotic states. And in people who are carriers who have sickle cell trait, for example, have higher levels of D-dimer. D-dimer is, as I'll show you more data in a moment, a risk marker for cardiovascular outcomes. We also learned in recent years that both sickle cell anemia and sickle cell trait are race-specific risk factors for thrombosis. And for sickle cell trait, one of the hypotheses about this is shown on the right, as nicely outlined by Rocky Naik and her colleagues, is that the valve pockets actually are quite hypoxic. And so even in carriers, the hypothesis here is that the red cells can sickle in those pockets and perhaps create a local hypercoagulable state that leads to DVT. So this is the data on sickle cell trait and ischemic stroke risk in regards, as well as other studies, Jackson Heart, MESA, and WHI. We all collaborated to do this analysis with the leadership of Hyacinth. And here what you see is the hazard ratio of stroke in people who have sickle cell trait. And the summary bottom line here is that the hazard ratio of stroke was 0.8. So on the other side of 1. So trending toward being a protective factor, but really not nearly statistically significant even in this very large study. And so really no evidence in this data that sickle cell trait is a risk factor for stroke. Therefore, it cannot be a contributor to the racial difference. I was sort of hoping it would be, because then it would afford a target population that we could treat and intervene on, but it wasn't the case. Lipoprotein a, many of you might be familiar with it. It's an atherogenic particle that includes an LDL-like particle and apolipoprotein A. And apolipoprotein A looks like plasminogen. It promotes lipid and inflammatory pathways in atherosclerotic plaques and is thought to enhance abnormal clotting as well. So levels of LPA are highly genetically determined, and about 1 in 4 people have high levels. And LPA is much higher. The distribution is much different in Black people compared to white people. So it becomes a candidate mediator for explaining racial differences because of that. What we found is that LPA was a race-specific stroke risk factor. So in Black people, the relative risk of stroke with high LPA was 2-fold greater, while in white people, there was no association of LPA with stroke. There was very little data on this previous to the study, and no data really published specific to Black people. And so, so this tells us that LPA is a candidate target for reducing the burden of stroke disparities in the United States that affect Black people. Interestingly, we saw this same pattern for cognitive impairment. I'm not going to show you that data, but I think it's compelling, and hopefully we'll be getting that published soon. So LPA cannot be easily modified. In fact, the levels go up with statins, which is our usual treatment when we find LPA in our patients who've had stroke previously. But there is a new drug in development that looks promising, and it's in phase 3 studies in coronary heart disease patients. And this is an antisense oligonucleotide that lowers LPA. And so I would hypothesize that this drug might be more effective in Black than white individuals. And I really hope that the trial investigators doing these studies are overrepresenting Black individuals in their studies in order to try to answer this question. So I don't need to tell this audience much about the hemostatic pathways, but we're going to discuss here common cardiovascular risk-related biomarkers of hemostasis balance, factor VIII, along with ABO blood group and D-dimer. So ABO blood group is associated with cardiovascular disease. There are many, many studies, many meta-analyses documenting this. And as you know, the ABO glycosyltransferase gene determines the presence of A, B, or neither antigen on red cell surfaces. People with non-O blood types have higher factor VIII levels, and this is due to differences in sugars that are attached to von Willebrand factor. And of course, that determines the clearance of factor VIII. And so those of you working in von Willebrand disease know that it can be difficult to diagnose von Willebrand disease in people with type O blood. And these traits are continuous traits. So we know from the cardiovascular literature that people with type O blood have the lowest risk of cardiovascular disease compared to the other groups. These are data from regards showing the factor VIII level based on blood group, and you can see the mean levels across blood groups, and people with AB blood type had the highest factor VIII level. So because of these findings and the knowledge that AB blood type is more common in Black people, and we also have known for years that factor VIII is higher in Black people, ABO and factor VIII become candidate mediators of the racial difference in stroke. So here's the data. What you see here is the relation of blood group with stroke. So O is the reference, it should have the lowest risk. And what you see here is the group with the highest risk is AB, which is also the group that has the highest factor VIII level, and really no association with either A or B separately. We also published in regards, it was one of our most popular papers in the media, that AB blood type is associated with cognitive impairment risk, with the risk of future cognitive impairment. And so, so really a quite compelling finding. Most research studies on blood group look at just O versus non-O, but we were able to genotype and classify the specific blood types. So when you add factor VIII to this model, what we found is that hazard ratio 1.8 went down to 1.3. So what that says is 60% of the increased risk associated with AB is explained by factor VIII, which makes sense based upon what we know about these biomarkers. So what about the racial disparity? Does it explain the racial disparity? There was not a difference between in Blacks compared to whites on the relationship of ABO with stroke. And in this now hopefully familiar plot, you can see that in the dark blue, this is the model without blood group included, and the light blue is the model with blood group included. And you find, and you can see pretty obviously, that there's no attenuation by adding blood group to the model. So the race disparity in stroke is not explained at all by blood group. So turning to D-dimer, again, I don't need to tell this audience what it is. I think of D-dimer as a marker of fibrin formation, at least when we measure it in epidemiology studies. And all of us are always making fibrin and breaking it down. We consider this a process marker. It's obviously not a causal factor. It's a byproduct of fibrin formation and breakdown. Higher levels are known to be associated with a variety of health outcomes, as shown here. And we've also known for a number of years that D-dimer is higher in Black than white individuals. And this is data from the MESA study, showing that both in men, shown in light blue, and women shown in dark blue, that D-dimer is higher in Black people than white people. And interestingly, it's higher in women than men as well, a fact that really is not explained. So this shows the relation of D-dimer with stroke, and it's the hazard ratio of stroke per standard deviation increment higher D-dimer. So you see at the top in the basic model, adjusted for age and sex, that that hazard ratio is 1.3-fold increase. So it's a little bit stronger than that relationship of the 10-millimeter increment of systolic blood pressure with stroke. But you see in Blacks and whites separately that hazard ratio is exactly the same. So no difference in the relationship by race with D-dimer and stroke. When you add the Framingham stroke risk factors to the model, there's really not much change at all in those risk estimates. In other words, not much confounding, if any, of that relationship by risk factor levels. And again, what I hope now is this familiar plot. In the dark blue, you see that hazard ratio of stroke by race without accounting for D-dimer, but accounting for the risk factors. And when you add D-dimer to that model, there really is no significant reduction in that hazard ratio. It looks like it goes down a little bit, but it wasn't statistically significantly lower. So D-dimer, appears to be similarly related to stroke in Blacks and whites and didn't seem to mediate the difference. So now we turn to inflammatory cytokines, and this paper was published about 1.5 years ago now in Neurology, and they made a nice infographic for us. The first author on this paper was Nancy Jenny, who some of you might have known. Nancy unfortunately passed away in an accident while this paper was due, and it's just the worst thing that can happen. In a research group, it was just terrible for us, but we were able to get the paper published on her behalf, and it was such a thrill that they then made this infographic for us. So the questions for this study is whether circulating levels of IL-6, IL-8, and IL-10 mediate the racial disparity in stroke incidence affecting Black people. And of these 3 cytokines, only IL-6 was related to stroke risk. And you can see here the hazard ratio of 2.4, and then after adjusting for other risk factors down to 2. This is a huge relationship. And to give you reference, C-reactive protein, which is a commonly accepted kind of inflammatory marker related to cardiovascular risk, really did not predict stroke very well in regards, and especially not in Black participants. The relation of IL-6 with stroke risk was similar in Black people compared to white people. So it's not a race-specific risk factor, even though the levels were higher in Black people. So this is the mediation analysis. Rather than showing the graph, I have it this way. So the top section shows a model that's simply adjusted for age and sex. And this is the model without IL-6 in it. You see these hazard ratios of about 2. And then when you add IL-6 to the model, the hazard ratios go down a bit. And the mediation was a 28% mediation at age 45, which was statistically significant. So IL-6 then mediating this unadjusted relationship. When you add the other stroke risk factors to that model, which is the lower half, you don't see any difference in this hazard ratio. So there's no mediation when you account for the risk factors before you put IL-6 into the model. So what this is telling us is that IL-6 appears to mediate the racial disparity in stroke via its association with risk factors, so that risk factors are creating an inflammatory milieu that then is leading to stroke. So this suggests that inflammatory treatment targets might be helpful to interfere with these pathways, but also that inflammation could be manipulated for risk factor prevention, as I mentioned briefly earlier. And we're working on that. So this is the relation of pack years with stroke risk. There's not a lot of data on this in the literature, actually. And this is Juan Conde's work. Juan is a fourth year medical student with us. And what you see here is increasing pack years expressed as quartiles of the distribution amongst people who were former or current smokers. And you see this strong relationship such that those with pack years over the median value, I can't remember what that value is, but over the median value, there was quite substantial increase in stroke risk, 2 to 3-fold increased. And here's what happens when you add IL-6 to that model, even though it's adjusted for other risk factors, you see a reduction in these hazard ratios of stroke. And it turns out IL-6 is explaining about 20% of the relation of pack years to stroke in regards participants. So it suggests the hypothesis that pro-inflammatory aspects of smoking are important in stroke biology and risk. So to summarize what I told you, I've taken you on kind of a whirlwind tour of several years of work. And I think I've shown you that some of the risk factors we're studying underlie the effects of traditional risk factors on stroke, like IL-6. Some are race-specific risk factors, so hold promise for reducing disparities, like Lp(a), and others related to stroke but didn't explain the racial excess. So evaluating them further wouldn't seem to help us figure out ways to reduce the racial disparity. And some of the factors didn't relate to stroke risk at all. And my postdoc, Deborah Kamin-Mukaz, published a really nice review of all of this talk, essentially, in Stroke Journal that came out just a couple of weeks ago. So I would encourage you to look at that if you're interested in getting more detail on this and you don't want to read all the individual papers. So it's our hope that confirmation of some of these findings is pursued. It's sort of difficult because there are not a lot of studies with large enough numbers of Black people to address these questions, but we hope that confirmation is pursued by others. And we hope that people who are doing trials consider these results and design trials, especially in stroke prevention and secondary prevention with stroke or preventing recurrent stroke, that includes significant numbers of African-American participants. We have parallel work, I alluded to it a little bit, going on around cognitive impairment and racial disparities in cognitive impairment, which we also have elucidated in regards. And we are currently avidly working to investigate the role of biomarkers in explanation of racial disparities in the incidence of risk factors, in particular hypertension, diabetes, and chronic kidney disease. So I'd like to thank you for your attention and acknowledge some of the people who were involved in this work. You know, in epidemiology, we work in herds, and this slide just lists some of the key people who've been involved in the the research that I presented to you. And I can't wait till we get back to where we can have meetings. This is our regards group meeting in Vermont a couple years ago for a working meeting to kind of do our science. And this is what it looks like when we get together. And I just can't wait till we can do this again. So thank you for your attention. I'd be happy to take questions.
Mary, thanks so much. That was fantastic. There are questions. I'm going to just open up the mics, or you can open up your mics yourself. So Jose, we haven't heard from you. Can you speak? Come on, Jose.
I can. Can you hear me?
We can hear you.
Yes. Mary, that was fantastic. I was just curious as to what is known about the pathophysiologic link between hypertension and stroke.
Well, so remember, there's 5 kinds of ischemic stroke, right? So it's different depending on the stroke subtype, but hypertension is, of course, a major risk factor for large vessel atherosclerosis. So large artery stroke, such as what occurs from carotid artery disease, for example, is fed into by hypertension. And in addition, in small vessel stroke, this is really where hypertension is very important. It's the perforating vessels in of the brain, such as in the basal ganglia, where small vessel stroke occurs. And small vessel stroke, hypertension is the main risk factor. It's these, remember in pathology class, the Charcot-Bouchard aneurysms that form in these small perforating arteries, and they're forming under conditions of high blood pressure, of chronic high blood pressure. Small vessel disease appears to be really super important for cognitive function as well. So that's a little bit of it. But we also think that the inflammatory aspects are important, whether it's kind of through the atherosclerosis, we're not really sure. And unfortunately, in regards, we don't have measures of atherosclerosis because it's a large, simple study. If we wanted to do like a carotid IMT or something like that, or even a brain MRI, you know, there's no way we could do it when we have 30,000 participants and we don't have field sites. Like, we don't really see these people. We just talk to them on the phone.
Are you segregating stroke types?
We've done a little bit. The stroke subtype data is really hard. So we get medical records to adjudicate the strokes and classify them as best we can for subtype. And so some of my strokeology, stroke neurology colleagues, they don't like it when I want to look at the stroke subtypes in my papers. So, you know, for the hemorrhages versus ischemic, it's pretty clear and we can classify them pretty well. But for the ischemic subtypes, it's difficult because based upon data coming out of medical records from hospitals across the country of all different types, we often have limited data in those medical records in order to classify the strokes. So a large portion become in the unknown bucket, and you sometimes get weird results when you try to do that. So we have in some papers looked at this, but my stroke neurology colleagues who actually did this work of adjudicating the cases, they kind of tend to discourage me from trying to read too much into it.
Peter Grin, I'm just going to call through. There's a bunch of questions. Peter, do you want to get on?
Sure.
Better to hear a voice.
Okay, can you hear me okay?
Yep, go for it.
Okay, that was a great talk. I'm just interested in that first 50% of the racial difference in stroke risk that you were talking about. You mentioned that socioeconomic status doesn't explain most of that, and you showed that with the data. So, but then a couple of the factors that you mentioned were poor diet and obesity. So I'm wondering if there's any data that links that in terms of race to the higher blood pressure, or if you're leaning more towards the increased inflammation being kind of responsible for that first 50% difference.
Yeah, we have looked at that. And the 50% thing is sort of simplistic because it's pretty much based on the prevalence of the risk factors and the level of systolic blood pressure. So it doesn't take into account sort of the exposure to the risk factors over periods of time or how severe they are, other than the systolic blood pressure, which is part of that analysis. There's a great person in our study, Suzanne Judd, who's a biostatistician and nutritional epidemiologist, who developed dietary pattern data. So at the baseline, we did a food frequency questionnaire to ascertain what people eat on a regular basis. And in that data, she used basically a cluster analysis to identify dietary patterns. And there's this, so a lot of us in academia, we have the dietary pattern that she labels alcohol and salads. It's kind of funny. That's the fact, we call it the faculty diet. But there is, in all seriousness, a dietary pattern that is called the Southern diet, and it's composed of high levels of fat and sodium and organ meats and fried food and sugary soda, sugary beverages. And the Southern diet does explain a portion of the racial difference in stroke. It's a whole separate analysis that wasn't included in that 50% that I showed you. And of course, we know this type of diet is also pro-inflammatory. I don't think we haven't looked yet at the pathway of the pro-inflammatory diet with stroke, and we probably should do that with the cytokine data that we have. Obesity is not really a clear risk factor for stroke in regards to data. The paper's not published, but there's this weird relationship where BMI does not seem to relate to stroke, but waist circumference does. And so, elevated waist, of course, is also a manifestation of inflammation, and adiposity is, of all the cardiovascular risk factors, it's the one that's most closely related to inflammatory state. So, I think all of those things are interlinked. We don't think of obesity as like a traditional stroke risk factor, but I hope that answers your question.
Yeah, for sure. Thank you very much.
Yeah.
Jacob Pendergrass.
Hi, such an interesting talk. I guess, the thing that occurs to me is that when you're sitting on this incredibly valuable data set that you constructed, over so many years, over such a huge geographic area, is you have an opportunity to look at the influences of temporal effects, in particular, the Medicaid expansion of the Affordable Care Act in 2014. And I'm wondering if you looked to see if that had any effect on racial disparities. I mean, that kind of analysis has been done for dialysis access and that kind of thing.
Yeah, that's a great question. So, we haven't done that particular analysis, but if anyone wants to, you're welcome to come play with us. Regards has published like 570 papers, and the majority were written by first authors with no funding from the parent study. We're like a really lean, mean, small investigator group. And you saw where the stars were on this, on that map. And, there's one or two people at each site. And so, we love to give away our data. And we have linkage to Medicare, for example, for the people who are 65 and older, but we haven't done that analysis. We tried to do sort of an ecological analysis around sugary beverage taxation and, or tobacco taxation as kind of trying to address the impact of health policies on these outcomes. It's hard to have the power in those analyses, and the temporality is a little bit difficult, but I think that's a great idea.
We can go all afternoon, but I got there's two more questions, Mary. Okay, for Wolfgang, do you want to jump in?
Yes, Mary, did you look at platelet function at all? There's this really well documented PAR receptor signaling differences with Black people having a much stronger response to thrombin. Seems like an obvious one that could play a role there.
It's really hard to do that for us because the pragmatic nature of this study, the people who are going in to draw the blood on our participants, some of them, there's 6,000 people that work for this company, and they often work out of their homes, and they don't always have a good centrifuge. And so, we set a parameter to get the blood samples centrifuged within 2 hours of the draw. But, centrifuges, we didn't have good platelet poor plasma, let's say. So, we can't really measure anything that emanates from platelets because we have contamination in the plasma. So that really doesn't work, but you could do it from the genetic angle. You could look at SNPs, and, again, welcome to collaborate. There's no one right now that's focused on that. We do have different kinds of genomic data and subsets, mostly in our Black people. It's interesting in the genomics revolution and the epidemiology studies. There's been a lot of cohort studies like ours that have generated really great data. And for our study, we were kind of late to the game in getting DNA available because we didn't have money to extract it. And actually our peer reviewers said it wasn't worthy in one of our renewal cycles. And so we had a hard time getting money to extract. It's expensive. It's like $30 a sample times 30,000. So we now have genomics data on all the Black people, but nobody wants our white people's DNA because there's so many other studies that have that. So we have, you know, ongoing efforts at genomics, and also we hope soon proteomics. So some of those questions can be answered with the genetic data.
Aggie, are you still on? Agnes Lee. Okay, I'll read it. Oh, you're there? What about gender, from fantastic review, Mary. What about gender differences? Do any of these biomarkers aside from D-dimer differentiate between men and women associated with risk of thrombosis?
Yeah, I see that question. You know, in some of our papers, we look for that, but we haven't always looked for it consistently. I'd love to do like a separate paper just on gender differences. We do see some gender differences in some of the biomarkers. And for D-dimer, I don't think we looked at it, but I can't remember. It was such a long time ago. But we definitely have some of our biomarkers, both for stroke and cognitive impairment, that seem to have gender specific associations. It gets very difficult because then you're looking at race, sex strata, and you start dicing your population and you start to lose power fast to kind of be clear about whether there are differences.
I guess that addressed the next part about Asians and South Asians.
Yeah, we don't have Asians and South Asians in regards. So we specifically only included non-Hispanic Black people and white people because that was the disparity we were aiming to study. And of course, in Asian populations, there's a disparity in hemorrhagic stroke. And you know, we aren't addressing that. There are other cohort studies with Asians and South Asians in the United States, like the SOL study, the study of Latinos in the US that can look at those kind of questions.
And are IL-6 inhibitors on the horizon, like statins, for those who don't want to quit smoking?
I'd rather have people never start smoking to begin with, which is why we need high tobacco taxes.
Right.
I'm not sure what the tobacco taxes are in Canada.
Probably higher, but anyway.
But you know, you need $1 increase to affect purchasing power of a person. So you know, in my work in advocacy with American Heart, we work on tobacco taxes almost every year, and that's a state level issue in the United States. And of course, in the South, you know, we looked at the tax data, and in the South, the taxes are like almost non-existent. So it's really interesting.
Tobacco country, I guess.
Yeah, but I'd like to. The primordial prevention is really, I think, the hope for the future. You know, just preventing the risk factors to begin with.
Yeah.
Through, optimizing childhood health, I really think is the means to that.
Obviously. Great. Mary, thank you so much. It was fantastic. We're glad you made the rush across the country to see us.
It's so great to see everybody and be here.
Yeah.
And thank you for all the interesting questions.
Terrific.
And if people have other questions, feel free to pop them.
Yeah.
Or a note on Twitter if that is easier for you.
Yeah, you can always find her there for sure. All right. Thanks again, Mary. All right. We're good. Okay, so I'm going to hand this over now. Just before we're having a break, but actually a poster sessions and a break, but and I think we'll just go for the 45 minutes. So we'll run a little late, but that's okay. So we'll I'm going to give this over to Stephanie.
Thanks, Ed. This is the poster list. So take a look at the poster titles. If any interest you, feel free to pop in there and check them out.